All right. Well, good afternoon and welcome to or welcome back to the Rockefeller Institute's 2021 Local Government Lab, a forum for New York State researchers, practitioners, and policymakers examining innovation and best practices in local governance. My name is Lee Wedenoya. I am an economist and senior policy analyst at the Rockefeller Institute, and I am absolutely delighted to moderate panel 5, which is serving vulnerable communities in times of need. Before I introduce the presentations, I want to highlight two upcoming opportunities at Rockefeller that may be of interest both to panelists and to audience members. We are currently accepting applications for next fall's class of Nathan Fellows. Many of our previous and current Nathan Fellows are presenting at Local Government Lab, if that'll give you some idea of the types of research that they do. We'll also be posting a call for proposals later this week or early next week for a virtual conference on developing effective evidence-based drug policy, and that will be held in October. So you'll be able to find out more information on both of those through our website or through contacting me or any of our other wonderful staff. So this session is going to feature 4 presentations. The first is from the Maxwell Lab, SNAP and Families in Need, presented by Michelle Kincaid, followed up by What Drives Staffing Levels for Substance Use Disorder Services in New York State, which is co-presented by Luke Nasta and Patty Strach. Then Opioid Treatment Deserts in New York City, presented by Shawn Hill. And finally, Applying the Multiple Streams Framework to the Urban Policy Process, co-presented by Alice Sardell and Michael Gusmano. And I apologize if I mispronounced anyone's name. I tried. So today is a full day of presentations, and we do have a packed session. So it's going to be a strict time limit of 15 minutes per presentation with Q&A afterwards. Please submit any questions using the Q&A function, not the chat function, the Q&A function, which you can find by hovering your mouse over the screen, and it'll be in the taskbar on the bottom. I would like to encourage everyone to ask questions as they occur to them, so we don't have to wait for the questions to queue at the end of the presentations. So before handing it off, I just want to thank all of today's presenters, both this session and the other sessions, for sharing their research with us in such a crucial time for work on local governments. So with that, I will introduce our first presenter, Michelle Kincaid, Senior Associate at the Maxwell X Lab of the Maxwell School at Syracuse University. Take it away, Michelle. Oh, Michelle, you're muted.
Of course. Thank you for helping me with that. Let me just minimize this. Okay. Thank you for the introduction. So as Lee said, my name is Michelle Kincaid. I'm a senior associate at the Maxwell X Lab at Syracuse University. And today I'll be talking about the lab's work relating to the SNAP program and families in need. Oh dear. So first, this is just a brief agenda of the things I'll cover. First, I'll talk about a brief overview of the lab. Second, the first project, which is SNAP recertification minders. Third is SNAP and temporary assistance. And then the last project I'll discuss is about increasing take-up of Help Me Grow. So briefly, the Maxwell X Lab is started in 2017. It was co-founded by Professor Len Lopo and Joe Boskovsky, and the mission is to build evidence for what works and to do good in the Syracuse community and beyond. What we do is we use behavioral science to create targeted interventions and really specialize in conducting field experiments, specifically randomized controlled trials, to confidently measure outcomes from those interventions. Another important component of what we do is collaborating with partner organizations. So these are often nonprofit organizations or local and state government agencies. And we work with them to identify a program or a policy that they would like to test or improve upon with an intervention. So in this work, we also utilize the scholars from the Maxwell School of Citizenship and Public Affairs, whose research interests often align with these types of projects. And so this includes tax policy, food assistance, healthcare, and other anti-poverty programs. And we also apply their expertise in publishing our findings in peer-reviewed journals. And that brings me to the first example I'll talk about. So this is a project that we actually shared some preliminary results with at last year's lab conference, and it ultimately developed into our first peer-reviewed publication. Here you'll see it's titled Testing Behavioral Interventions Designed to Improve On-Time SNAP Recertification. So this project was led by Professor Len Lopo, Professor Colleen Heflin, who is an expert in food policy and food assistance in the Maxwell School, and Joe Boskovsky, who was the lab's managing director at the time. And the authors sought to understand how behavioral interventions designed to increase the likelihood of SNAP recipients, how that improves the likelihood that they'll recertify on time, specifically in Hennepin County, Minnesota. And so this project ran through January 2019 to February 2020, and it was a 3-arm study comparing the efficacy of the Hennepin County recertification auto dialer communication, essentially like a robocall, to a behaviorally informed message, and a 3rd arm with both the auto dialer and our text message against a control group that did not receive any reminder aside from standard written communication that is given to all of the recipients. So this slide is trying to just demonstrate a bit of the timeline for how this works, and also illustrates sort of the problem that's trying to address, which is administrative churn. And this is when a household exits and enters SNAP within a 4-month period. And this not only imposes costs on the SNAP household, but also the SNAP agency that is processing the cases. So you'll see at the beginning, there's the state packet that I kind of mentioned, which is the control sort of business as usual information that SNAP recipients get about 45 days before the recertification date. This informs them of the deadline and any necessary processes to recertify. This is required by federal law, and also describes that they must complete an interview. And so in the process, the authors realized that this was not a feasible entry point for intervention due to a lot of the regulatory restrictions on the language in the packet. And so they decided to focus on the auto dialer and its impact on recertification. So you'll see the typical step 1 is when it usually kicks in to remind recipients of what to do, and then there's another notification closer to the deadline. And what the authors did to basically administer the RCT aspect of this is that they use administrative data on individual SNAP cases and created interventions approximately 20 days before the recertification deadline. So first, this is an example. I want to show the kind of messaging that was in the auto dialer. So this is the exact message that callers received. And you can see just visually, it's pretty long. There is important information in there, but you could imagine at the end of a call, or maybe if you don't even pick up the call, it is not clear the call to action, what to do next. So the authors designed a text that was given to recipients who had a functioning mobile number that could receive this information. And just due to the, you can see it's shorter, and that's due to the constraint of 160 characters in a text message, but also it was important to keep this short, kind of short and sweet, and also embed a lot of the behavioral science principles that we wanted to test. So you'll see it starts, hi, County Human Services. We will text you reminders about your benefits. We want you to keep your food benefits and fill out the forms mailed, and which essentially summarizes the end of the auto dialer call. So in bold, the second and third sentences used, they use first reciprocity and then loss aversion. So in the first reciprocity, we will keep, or we will text reminders about your benefits. This is related to the idea that people have a positive response to a friendly behavior, even when no material gains are expected. And then the third sentence, we want you to keep your food benefits, relates to loss aversion, which is the notion that people tend to dislike losses much more than they dislike gains, in short. So these were two very important things that the authors want to include and see how they would impact recertification. So this is a short summary of the results. So this chart shows the average on-time recertification rate for this 3-arm RCT. This is for the full sample from June 2019 to February 2020. And you'll see the first column is no auto dialer. So these were the people that just received the state packet. And that's, hovers around 50%. You'll see, interestingly, the auto dialer by itself was not an effective reminder. And then the last column is the text. And so really in summary, so the interventions with the text messages, were improving recertification rates around 3 percentage points over no additional message and around 2 percentage points over the auto dialer being currently used. In the paper sent around related to this, there are charts with other panels related to how this changes by age and education level. So I wanted to mention that it was really interesting that the authors found that the texts were also particularly effective for SNAP recipients under the age of 60 with low to moderate levels of education. And across all the panel groups, the auto dialer was never a statistically significant improvement over no reminder at all, which is the no auto dialer. So this is really important finding, just given the broad utilization of this type of service across many fields, especially the social sciences or social services. So on to the next. This is a related project in that it's also addressing SNAP, but also temporary assistance. And we're interested in looking at this in Onondaga County. This project is currently in development. It's an effort with the Office of Temporary and Disability Assistance for New York State. And we're interested in understanding the, uncovering the potential barriers preventing SNAP recipients from concurrent enrollment in TA, temporary assistance. In May 2020, there were nearly 3 million SNAP recipients in New York State and just over 900,000 recipients of TA, even though many SNAP recipients are also eligible for that program. And so we're interested in focusing our study in Onondaga County because that's local to the XLab, but also is also the fourth highest SNAP caseload in New York. And Dr. Heflin, who was involved with the previous project, will also be involved in this. And we will work on creating an electronic, ideally text-based survey that will be administered to SNAP recipients not enrolled in TA, questions that we'll try to investigate why. And we also are interested in doing qualitative interviews with street level staff for uncovering any additional context to these barriers. So the last project I'll describe in brief is increasing take-up of Help Me Grow in Onondaga County. This is currently in the field. It's a collaborative effort between the Early Childhood Alliance, Help Me Grow, and the CNY Diaper Bank and the Allen Foundation. And we're really interested in understanding if behaviorally informed messages could encourage parents to engage with Help Me Grow. And Help Me Grow is a social service organization. They provide they serve expectant parents, children aged birth through 5, and those that care for them, and they complete referrals to community agencies, but also administer child developmental screenings. So we know there's significant overlap between the population of CNY Diaper Bank and Help Me Grow. And so we designed a sticker that's placed on the top of a formula can that's distributed by CNY Diaper Bank. And there's a text or a number that we hope people will text to get in contact with Help Me Grow. And so part of the intervention, in summary, we designed these stickers with a target population to generate feedback. So they're really relevant and just with their knowledge, which is really important. The message is printed on the sticker, as I said, on the top of the formula can, which is really important because it's kind of the highest touch point for this message. And we also procured some texting software that will help centralize these texts, but also disentangle, this outreach from Helmigo's current communication line, which is the 211 number. So we're really excited about this and looking forward to sharing any results from that soon. So that's the end of my presentation. Thank you, and I look forward to your questions.
Thank you so much, Michelle. For our next presentation, we have Luke Nasta, who is Chief Executive Officer of Camelot Consulting Centers, and Richard P. Nathan Fellow at the Rockefeller Institute, and Patty Strach, who's a Professor of Political Science and Public Administration and Policy at University at Albany, and she's also a Fellow at the Rockefeller Institute. Luke and Patty, take it away.
Thank you, Lee. I'm going to start off and give the appetizer and then turn it over to Luke for the main course to talk a little bit about our results. All right, so we worked on a project to look at staffing levels for substance use disorder services in New York. And just to give you a sense of what the problem looks like, sorry about that, is that the United States has long had a problem with a staffing shortage for substance use disorder services. So it's not a new problem. It is a problem that affects across the spectrum people who work in this field, everything from kind of day-to-day counselors and peer specialists, all the way to physicians and psychiatrists. And we know there's plenty of research to tell us about what this looks like and why there are these recruitment and retention problems in this specific field. And so some of the ones that the literature points out that we really wanted to look more at are things like burnout. It's a really tough job. It requires a lot of attention. There were some looking at management practices, that there are credentialing and licensing barriers. So people have to be licensed and credentialed to provide services. There's not always adequate training to meet those credentialing and licensing requirements. And then there's low wages, high caseload, and stigma. Now, there's not enough people working in the field. And as a result, it's harder for people who need help to get help, right? When there's not a doctor, when there's not a nurse, when there's not a counselor, when people show up to get care, it's not always available to them. And we know that the problem is getting worse. So during the COVID pandemic, we have had the highest overdose rates in this country that we have ever seen. And the latest data say about 92,000 people died from a drug overdose, and that number is expected to go up. So we know that more people are affected. But there's also a problem that providers have a hard time keeping staff. And this, again, was also exacerbated during the pandemic, right? That these people are essential staff, but they're not treated that way, right? So they're working in these difficult conditions, doing these difficult jobs, and they're not given the respect that they deserve. So we know that this, this is the national picture. This is, sorry about that. This is the, I don't know why this is moving on its own, but it is. All right, so we know that this is the national, okay. This is a national picture that we've been providing to you, but the same kind of problems take place in New York State. So what we wanted to do is to get a sense of what is happening in New York State. And we wanted to figure out, so given what the New York State picture looks like, we can get a sense of not only what the problem looks like, but what are the kinds of policy solutions that are likely to effectively address this problem. So to do this, we partnered with the New York Association of Substance Abuse Providers, that's ASAP, to field a survey. It was an internet survey, and it was sent out through ASAP's listserv and also the New York Office of Addiction Services and Supports, OASIS, both to their listservs, and we had over 660 responses to that survey. And I'm going to turn it over to Luke now, who's going to tell you a little bit about who responded and what they said.
Thank you, Patty. Okay, good. We're on who participated. Can I be heard clearly?
Yes.
Yes, good. So what we see here are the modalities of care that responded. And this was the survey that went to on the left side of the screen, that went to administrators. And so it was residential, outpatient. MAT stands for medication assisted treatment, which is the big push to get people on medication. Prevention, recovery, harm reduction, other. And the number of full-time paid counselors that each agency had on board. So my screen is actually, let me see if I can, yeah, that's good. Because I don't need to look at myself. The number of full-time paid counselors, you can see there that either 1 to 10 counselors all the way up to 41 or better counselors. So we were very fortunate, in my opinion. We're very fortunate that we got such wide cooperation throughout the entire state from all different modalities of service, from residential to prevention, recovery, harm reduction, medication assisted treatment. Those are all, they could be in and have been in the past sort of operating in silos. But ever since the opioid epidemic began, there's been a greater collaboration and more, and so that encouraged participation in this survey because those who do this kind of work, regardless of the discipline, realize that there's a terrible staff shortage and that we're really unprepared to, as a state or as a nation, to treat the people who have been afflicted by addiction. We can move the slide, please. Next. Okay.
I'm sorry, Luke, I'm losing control of this.
Thing is, this is my debut, fellows, and that this would happen.
Alex, can you put the slides up? Because this won't work on my end.
It
Sure
just
thing, Patty, getting on it now.
Thanks.
keeps jumping slides. So page 7 would be next, Alex. Yeah, you're on it. Don't move. Okay, good. Thank you. Of the agencies, again, this was 2 parts. This survey was 2 parts. It went to administrators of agencies and it went to the counselors themselves who work for these things. So we can do get 2 different pictures, or maybe 2 similar pictures. We decided to be ambitious and try and not only get administrators to respond to it, but get counselors to respond. And it was a very, very good turnout. So the number of clients that they serve, this is agency by agency, as you can see, 100, 300, 750 better. So they have high numbers of people at individual agencies work. That doesn't necessarily indicate that that's a good. Just indicates that there's a limited amount of services and everyone is packed into it, tenement in a city. Anyway, their budgets range from under $500,000 a year, $1 million, $9 the majority are between $1 and $10 million a year budgets, and then minority is 10 million or better. And there are agencies that have upwards of $100 million in their budgets as they're spread out across multiple regions. So just to give you another picture, another aspect of the picture of, what the system looks like in New York State to address this opioid epidemic. It's not just an opioid epidemic, it's the drug misuse epidemic. Okay, if we, Alex, page 8, please. Great, don't move. Thank you. Staff retention. Again, left side, administrators, right side, counselors. What you'll see there is that how long people are lasting at their positions. Counseling staff, and we also asked about support staff too, because though the counseling staff is of course your frontline direct service people, they can't exist without an infrastructure backing them up, support staff, and also we're looking to determine how society values these type of services. And so that one of the indicators would be staff turnover and people leapfrogging from job to job. So you can see that counseling staff 1 to 3 years, and then it starts to switch from 3 years and above, that the support staff who have stayed that long continue to stay at least above 50%, slightly above what counselors. The counselors themselves, on the right side, when questioned, show that they show a high turnover. Right, 1 to 3 years, they're saying that 27% of them are turned over, and the support staff also is a high level of turnover. Doesn't exactly correlate with what the administrators are saying. Oh. And then you can see it drops there during 3 to 5 and 5 to 7. In the 7 plus years, it actually flips from the 1 to 3. So to counselors, 47%, and support staff down to 26%. What we see here is an unstable system. We see a system of turnover, needing to change jobs, needing to change employers because of lack of opportunity, lack of adequate compensation, not great work. That's what we're seeing here, is an unstable system. Right now, again, we're talking about a frontline system that is addressing this epidemic that's going over 100,000 people a year in deaths, and that's the top of the iceberg of the contagion, because those are the deaths, not to minimize them, but What's happening under the surface as the deaths increase? Contagion is spreading. Okay, next page, please. 9, thank you. Okay, so administrators say that they pay their staff by position and credential. So there's an example of how administrators responded to that question. Obviously, if those with credentials have an opportunity, but it's not much of an opportunity when you look at that pay grade, $20,000 to $30,000 a year. Certainly in the inner cities is, that's poverty. That's poverty wages. You're not supporting a family on $20,000, $30,000 a year. So what are you encouraging? You're encouraging people to make a commitment to do this kind of work and continue this kind of work and continue to work for one agency, which longer they work for one agency, the more effective they will be, the agency will be, etc. That's not what the results are indicating. Clearly, with higher education credentials, there is a greater compensation. The CASAC, in case you wonder what a CASAC is, that's a Certified Alcoholism and Substance Abuse Counselor. It's kind of not, they keep changing what to call it. We don't call it substance abuse anymore, but not everything. Some ways of describing it is lagged behind. And if you ever hear national elected officials talk about it, they still call it substance abuse. Try to get away from that because it's judgmental, it's critical, it's not compassionate, and now we call it substance abuse.
You're just about out of time. Can I get you to wrap up a little bit?
Okay, well, go ahead. 80% of the count are underpaid and their salary should be increased. Okay, so we're seeing that. I mean, no matter who we ask today, do you want your salary increase? You're going to say yes, but we're looking at 77% saying that their salary should be increased. Okay, page 10.
All right, you are out of time.
I am out of time.
Yeah.
Oh, sorry about that.
All right, thank you so much. All right, for our next presentation, we're going to move on to Shawn Hill, who is an instructional technologist for digital scholarship and pedagogy at Fordham University. Thank you so much for being here.
Sorry about that. So my name is Shawn Hill. I work at Fordham University as an instructional technologist, and I'm going to be presenting today about what we have termed opioid treatment deserts within New York City and how those deserts both reinforce and are reinforced by processes of systemic racism. So in addition to working at Fordham University, I am also a co-founder of an organization called the Greater Harlem Coalition. The Greater Harlem Coalition comprises of approximately 110 faith-based organizations, block associations, small businesses, not-for-profits, and other organizations in Harlem, in New York City. And we have come together to address the fact that as a society, as a city, and as a state, we have repeatedly oversaturated communities of color with substance use programs. So in order to visualize the oversaturation of these programs in low-income communities of color, one of the things that we have done is submitted numerous FOIL requests to both New York State agencies as well as New York City agencies. And this has allowed us to come to this idea and to explore this idea of an opioid treatment desert. The data that I'm going to show you today all comes from a FOIL request to OASIS. I know the name has changed, but it was known as the Office of Alcohol and Substance Abuse Services. And the data is all, it's an annual tranche of data that comes from March 1st, 2019 to February 29th, 2020, in order to avoid the impact that COVID has had on the data. So first of all, the data that we received is zip code based. And so it's important to know that New York City has just under 200 zip codes in the various 5 boroughs. If you know anything about zip codes in New York City, you know that in addition to having zip codes that reflect residential, perhaps industrial or commercial, we also have zip codes just encompassing a single building, which may be commercial and there may not be any residential component to that building at all. So zip codes are certainly imperfect, but it is the spatial metric that we do have, and I'll walk you through this today. So the first analysis we did was to look at the zip codes and to simply discover how many of them have opioid treatment programs and how many do not. And the balance is around 80-20. Approximately 80% of all zip codes in New York City have no opioid treatment programs, whereas there is a concentration in about 20% of the zip codes that have all of the rest of the opioid treatment programs, which number around 68, 69, depending on the year that you take a look at, just under 70 programs throughout the 5 boroughs. And a map of the location and the size, and by size I mean admissions to, the map of the location and size of these opioid treatment programs in the 5 boroughs displays a clear non-random pattern. And when you look at this pattern, if you know anything about the social, the economic, the racial geography of the 5 boroughs, you are probably struck by the fact that this map could almost have been equally termed a map of low-income communities of color, because the larger dots that you see, the larger opioid treatment programs or OTPs, tend to be located in that kind of community. Those wealthier and whiter neighborhoods are areas where we don't see those programs located. So the question might then be, all right, well, maybe certain neighborhoods, certain zip codes don't have anybody in opioid treatment programs. And I think this goes back to the previous presentation, which is essentially all New York neighborhoods have people who are afflicted by the scourge of addiction and who are in OTPs somewhere within the 5 boroughs. And in fact, there were only 16 out of that almost 200 zip codes where there was literally no one in them who was attending an opioid treatment program. And that map, again, keen observers or people informed about the geography of New York City will see that the inhabited areas of New York City, virtually all the inhabited areas of New York City, have somebody who's in an opioid treatment program dealing with the consequence of addiction. If you look carefully and you note the black areas where there are no patients living who are in opioid treatment programs, you'll recognize such places as LaGuardia, the World Trade Center, Brooklyn Navy Yard, Fort Trotton, etc. There is one anomalous zip code on the extreme east of New York City, bordering Long Island. That is a zip code, a notorious one, 11005, which is a 3-building zip code called North Shore Towers. And that is a very anomalous zip code. It has an extraordinary set of statistics about it. And this, of course, brings to the fore the point that the vast majority of people attending opioid treatment programs are people who are less likely to have the economic means to go to, for example, a treatment program, a detox center in the Poconos, or to get private care in private doctor's settings, for example. So the opioid treatment programs tend to skew poorer, and so it is not strange for me to see that an extremely exclusive zip code may not have anyone attending a program. That's not to say that there's no one in that zip code who's not addicted and suffering from that. So if we assume that virtually all New York zip codes have at least somebody attending an opioid treatment program, but these programs are over-concentrated in communities of color. How many people, therefore, are living, who are attending these programs, live in opioid treatment deserts? What kind of percentage of people? Is it just a very small number? Is it a very large number? If, for example, wealthy and whiter neighborhoods at very, very, very small numbers attending, we would expect that number to be very low. But what we find is 2/3 of the people attending OTPs have no local program that they can go to. They have to become what we call opioid treatment commuters. So they have to travel out of their neighborhood to go to some other place for treatment. And our analysis of the people who attend Harlem and East Harlem OTPs is actually incredibly striking. First of all, only a quarter of the patients who attend opioid treatment programs in Harlem and East Harlem live in Harlem and East Harlem. The vast majority live in the Bronx, another, about double the number. We have other people coming from different parts of Manhattan, from Queens, from Brooklyn, from Staten Island, for heaven's sakes, coming all the way to Harlem or East Harlem for their treatment. And 8.3% of the people attending programs in our community are coming in from Rockland. They're coming in from Orange. They're coming in from Long Island, from other parts of New York State for their treatment here. And this practice of oversaturating low-income communities of color with these programs and asking the residents of other frequently wealthier neighborhoods to commute for their care becomes part of a cycle that exemplifies how systemic racism both reinforces the racial stereotypes that addiction is a Black or Latinx problem, as well as burdening those vulnerable communities, which, as we all know, have many other issues to contend with, in addition to being the host of addiction programs. These communities essentially shield wealthier and frequently whiter communities from having to have those programs in an equitable way or a fair share way in their midst. So the cycle is, I think, fairly self-evident. Sites are located, initially were located in the early 70s when methadone first came online to address the 1960s heroin epidemic. They were tended to be located in low-income communities in Manhattan, for example, the Lower East Side, near Port Authority, and in Harlem and East Harlem. So the perception builds that this is a community of colors problem. More programs therefore get located there because we imbibe the idea that it is a Black issue, it is a Latinx issue, and more people commute in, again, further reinforcing that idea. And this cycle goes on and on. So that is my presentation. I wanted to get through it so that we would have lots of time for some interesting questions from the audience and from other panelists. And I look forward to that. So Lee, I'm going to pass it back to you.
Great, thank you so much. So we are moving on to our last presentation, which will be Alice Sardell, a professor in the Urban Studies Department at Queens College, and Michael Gusmano, who's a professor in the School of Public Health's Department of Health Behavior Society and Policy and Administration at Rutgers University. And
Thanks.
after that, we'll have questions. Thanks so much.
Great. My colleague Alice is going to begin, and then I will introduce our case studies.
Okay. Michael, move it to the next thing. Before we start, I have to say one thing to Shawn. Shawn, I live near North Shore Towers. Not only is it what you showed in terms of income and ethnicity, but it's pretty much people over 75. It's a place where seniors live.
Very much so.
Another reason why they wouldn't necessarily be using programs. So, okay. Michael and I are basically taking the multiple streams framework, which some of you are probably very familiar with and some of you may not be familiar with. So I'm just going to briefly talk about the framework and the methods. So we're using the framework and we're applying it at the local level, which has not really been done. So I'm just going to briefly go through the framework. Okay, next slide. Oh, I'm sorry. So going back to the other slide. So our question is this framework, which is very much used in the study of the policy process, is this framework useful at the local level? And if so, does it need to be modified when examining urban and local policy? Okay, now then next slide, where I'm going to talk about the model very briefly. So it's very different from other models of the political process because it says the policy process is not linear. It's based on kind of the garbage can model. It's not linear, but it's a series of simultaneous policy activities, or at least we're looking at the policy process as a series of simultaneous policy activities. And Kingdon, who published the model in 1984, says that there are three streams: the problem stream, where the problems are identified as important to remedy, and he talks about some of the indicators and ways those problems are seen, which I won't go into. The policy stream, which is where ideas are discussed and kind of swirl about, and the policy stream, in the policy stream are members of the policy community. And anybody and all the people here who have presented, who work in policy, know that this is very, very valid in terms of on the ground, that there's a policy community in which specialists in a given policy area, whether it's drug use or whether it's energy policy or whether it's health policy, interact with each other from various institutional positions, both in and out of government. That's this legislative staff, agency staff, outside advocates are interacting together and they're talking about policy. And that's very important. And those people are in this policy community. And then there's a political stream, which really just means the larger political environment. Some things like which political power is in power, which political party is in power at a certain point in time. So the multiple streams model, when it's used, is also very often used with framing as a key advocacy strategy. Michael, you want to move to the next slide? Left out one thing from the slide before, which is the policy entrepreneur, which you don't have to go back. The idea that certain individuals inside and outside government are very invested in a policy idea and they spend their resources pushing it. So whether Kingdon's full theory, which also has to do with the policy streams coming together, whether or not that the idea of the policy window, the idea of the three streams coming together, whether or not that is valid, we feel like aspects of the framework are valid in our previous work. And now we wanted to apply it to the urban level. As I said before, it's not very often applied. There are some cases of applying to the state level, but not really many of those. So what we did is we did a document review of our three cases, and we did stakeholder interviews. And now Michael will talk about the cases, and then I'll come back at the very end for just our conclusions.
Thanks, Alice. So I'm going to go relatively briefly at a high level and just talk about these three cases. We looked at universal pre-K in New York City. We looked at home visiting, actually multiple home visiting programs, but particularly focused on the one that was developed in New York City. And then we looked at an effort to expand access to coverage for undocumented patients. So starting with universal pre-K, as many of you probably know, Mayor de Blasio made this a major part of his campaign back in 2003. And he really framed this, kind of going back to what Alice was saying about the importance of framing and shaping policy, as a program that would address income and wealth inequality. So it wasn't just about education, but it was really about redistribution and creating a fairer society. And in many respects, and all the lessons with regard to the multiple stream framework in a moment, this fits very well with the idea of the mayor playing an entrepreneurial role, but it also highlights the limits of city government and emphasizes the importance of federalism, which we'll get to. And so, as some of you may recall, the mayor had quite a big fight with the governor, which is not unusual, particularly about the need for raising taxes to pay for this, and they ended up having to compromise quite a bit. He did get some money for universal pre-K, but had to back down, for example, on his opposition to charter schools in the city. So again, he was kind of the classic policy entrepreneur. He framed the issue to fit what he considered to be the political mood of the city, and he helped create a window of opportunity, both for shaping public opinion, but also generating interest group support. There was already a long history of interest groups supporting the idea of universal pre-K, and he helped marshal them together. Again, as you will hear in all of our cases, the streams framework really does have to be modified to include federalism as an important context for making sense of policymaking at the city level. Similarly, with home visiting, there's a long history of trying to develop some level of home visiting to address the needs of mothers and their children and to improve outcomes of various kinds. And so both local philanthropies and policy at the city and the state, and frankly at the national level, had been working on developing home visiting programs for decades before the city program was adopted. It was a solution to the notion of income disparity in maternal and child health and development, and the prevention of child abuse and neglect, which was an important component of this, particularly early on. The idea is that nurses, social workers, and or community health workers would provide emotional support, parenting skills and education, screening, and make referrals to other services. But there are multiple models, and multiple models exist within New York, and that's an important story. One really big driver of this, particularly in New York City, but also at the state level, was from the Nurse Family Partnership, which is a national organization, and it was really driven by another policy entrepreneur, Dr. David. Going back to sort of Michelle's comment actually about the importance of evidence-based policy, this was part of what Olds did to help drive this onto the agenda and to get support for his particular version of the program. He and the entire Nurse Family Partnership organization placed a great deal of emphasis on conducting outcome studies to establish that this was not only an effective approach, but a cost-effective approach, which turns out to be rather important because some of the other models relying on community health workers tend to be cheaper and so therefore attractive to policymakers. And so Olds and his colleagues placed a lot of emphasis on the importance of evaluation and data, which appealed not only to the Bloomberg administration, where they first started having these conversations, but people in the de Blasio administration as well. Another important entrepreneur in this case is a place called the Schuyler Center, which some of you may know. It's located in Albany and is a major policy and advocacy organization focused on health and social welfare. One of the things that they did was to try to promote home visiting regardless of the model. And so they established a set of meetings that would bring together all of the advocates, and eventually also brought in people from state government to meet regularly and have conversations. And the idea was that the sort of rising tide would lift all boats. And so they wanted to kind of coordinate their message to the state legislature to increase funding for home visiting more generally. They also focused in the city level with DOHMH and the city council were being particularly supportive of these programs. But here, unlike the first case, the mayor was not really a policy entrepreneur, was not directly involved in pushing this. So again, this is another instance where federalism becomes terribly important. You have to pay attention to what's going on at all three levels of government to make sure to understand this and to look at the interaction among the policy communities that are in. Finally, just very briefly, I want to talk about New York City Care with universal access to healthcare for particularly undocumented immigrants. This is a program, it's a direct access program that was developed at the city level to really build on the existing safety net and to not only provide free primary and specialty care and drugs at the city's safety net, but to really coordinate the care for this community and to let them know that these were safe places to come in. One of the things that gave this great impetus, again, the mayor provided some significant, played a significant role as a policy entrepreneur. And one of the things he did was to appoint Nisha Agrawal as Commissioner of Immigrant Affairs. She had been in the advocacy community and she helped organize the mayor's task force on immigrant health, which developed a recommendation for a direct access program. And following a one-year pilot program called Action Health New York, in January 2018, Mitchell Katz came on. He had been a creator of a primary care access program in California and helped further push this forward. Again, going back to the streams and how this relates to our case, there's a longtime advocacy policy community that the mayor helped to tap into, in part by creating a window of opportunity, by placing emphasis on this issue and appointing a member of that advocacy community to be part of his administration. The other thing that's important, and again, thinking about how the federal level can trickle down and shape what's going on at the urban level, is that the ACA itself created an opportunity to do something about access to care for undocumented immigrants. As Peter Hall and a variety of other people have written, one of the problems the ACA created is that by expanding coverage, one of the few groups that were left that would be ineligible for some form of coverage under the ACA were undocumented immigrants. And so it really sort of created a need to address them. And then de Blasio sort of helped to shift the political stream and appointed a legal rights attorney and immigrant advocate as the commissioner, and this helped as well. So now I'm going to turn this back over to Alice for final thoughts.
Okay. So I think that Michael has said it very well, that the multiple streams framework is very useful. This idea of looking at the relationships, which we did, and we can't talk about in detail here because of the short time, the relationships between the advocacy community in these different cases, particularly in New York City Care, where there's a very strong advocacy community for immigrants for a long time. And in New York City Care and in home visiting, and in the home visiting cases, Michael said, the particular role of the Schuyler Center, which by bringing lots of programs and lots of advocates and people inside government together helped helped when they were going to the legislature to get money. So the role of policy community, looking at policy communities is very useful for looking at issues at the local level, and understanding the role of policy entrepreneurs is very useful. The idea of the political stream is very useful because, as Michael said, in the two cases of New York City Care, well, mostly in the case of New York City Care, it's very clear that it was when de Blasio was elected, well, both in New York City Care and in pre-K, de Blasio's election was a shift in the political stream. The political environment changed. De Blasio brought in progressives. And so that was the window of opportunity for both pre-K and for, brought in a progressive agenda in the case of pre-K and brought in advocates in the case of New York City Care. So that was the shift in the political stream. Part of the political stream is also the institutional context and the strong mayor role in two of the cases, the executive budget model in one of the cases, and this dense overlapping interest group community in social welfare in all three of these cases. So our overall conclusion is that the multiple streams framework is very useful, but it has to be used by looking at all the streams at all three levels of government. And so we really end up saying, yeah, the multiple streams framework is useful, but it's really 9 streams and not 3 streams. Something we left off the slide, the idea that you really have to look at the 9 streams and understand how the streams interact with each other. For just one example, and then I'm going to end. So as Michael said, it was because of the ACA, the advocacy community in terms of access to health insurance in New York City and New York State before the ACA was not really just focused on undocumented immigrants or even immigrants. There was a concern about how to cover everybody. But once we had the ACA, that shift in the federal political stream led to this focus on immigrants and led to a program designed for undocumented immigrants in New York, which is what New York City Care is called. Although, going back to framing, it's not really framed that way. It's not framed publicly that way, although that is in fact what it is. So I think that's, Michael, do you want to add anything?
No, I think we should wrap it up and go to Q&A. Thank you.
All right. Thank you so much to all of our panelists. We have a few questions coming in, but because I'm the moderator and I get to, I'm going to ask the first question. So this is for all the panelists. I think that there are a few strains that are coming through all of this research, which is the sort of lack of resources that confront a lot of these particular local endeavors, both in terms of the ability to assess them, to just see what that problem is in that 3 streams, and also to design effective policy. So if anyone has additional comments on sort of how lack of resources might have been magnified by the pandemic and who wants to talk about that, that would be wonderful.
I can easily apply that to the increase in opioid or drug misuse deaths during COVID. The epidemic of deaths resulting in deaths existed before COVID. When COVID came, rightfully so, we predicted that the additional stress, the isolation would contribute to the drug misuse and would ultimately result in more deaths. And that is precisely what happened. And you know, my point is that we have been unprepared to deal with those consequences.
I want to add something. Should I unmute?
Go for it. Yeah. Oh, you're muted.
You just muted yourself.
Okay. All right. There were 2 parts of that question, and I want to put them together and go back to the idea of framing. And that is that in health policy, and I would probably think, we have these silly barriers, but because you could say that drug use policy is also health policy, but in health policy, I think the pandemic has led to fewer resources, but in the end of the policy process, resources partly come from framing. And I think the pandemic has really been a framing mechanism in certain ways for more resources. That is the disparities, because what the pandemic showed, which is what people who studied healthcare and worked in healthcare knew very well before, the tremendous disparities by social class and ethnicity. So,
Although, if I could jump in, I do think one of the issues there is sort of translating that sort of better understanding and the way in which the pandemic has highlighted those disparities into greater funding for these programs. So if for another paper I did with Colleen Grogan recently, we looked at the funding coming from the CARES Act to hospitals. And this was designed to address the needs of hospitals who were disproportionately affected by COVID. But what we found is that on a per bed basis, most of the money actually went to fairly wealthy hospitals and not to the kinds of safety net hospitals that are actually addressing the needs of all of the populations that all of the panels are presenting. And so that sort of underlying power is still there, regardless of the sort of the greater understanding. The other thing I would say about funding, not necessarily related to the pandemic, but in our case, it becomes really relevant. And Alice and I have talked about this. One of the reasons we're presenting 3 relatively successful cases with both city and state funding for poor and vulnerable populations. But one of the things that has made them attractive is that they're relatively cheap. And it isn't at all clear whether or not the level of support would be maintained if they were a lot more expensive to do.
If I could just talk about the ground truth as opposed to sort of the theoretical perspective, our experience in Harlem during the pandemic has been an increase in open drug use in large, dense urban centers. Drug use tends to be a public, or at least an out of door thing. It contrasts greatly with the rural or suburban use of drugs, which is more hermetic, private, within the confines of one's home. There's been a great increase of public use. That is a combination of all the factors that Alice mentioned, but also because of both bail reform, the NYPD essentially pouting because of bail reform, and refusing to get engaged with low-level drug use or drug dealing. And so we have seen incredible increase in the use. And again, we're not quite sure how the shift in homeless accommodations has impacted that, from congregate shelters to individual rooms within hotels. But we also believe that there's a link there. We haven't quite teased it out, but that shift from congregate shelters to individual hotels has somehow also increased the street experience that our neighbors have in encountering drugs being used directly.
So I think that segues nicely into a question about, for both you, Shawn, and for Luke and Patty, about how both of your research sort of intersects. So one of the reasons that Luke posed for why there's such a problem attracting people to the substance use workforce is these other aspects of the job, these sort of atmospheric aspects, the difficulty, the locations. And you're finding that these treatment centers are generally placed within locations that are very specific and are now, through these other causes in COVID, being kept dangerous or being kept sort of away from other society. How do you think that this sort of systematic placement of these centers interacts with the inability to attract a consistent workforce?
I actually have a concrete example from a meeting yesterday that I can feed to Luke directly. So yesterday, our organization was in a meeting with Harlem United, which is not an OTP provider, but it does education, outreach, counseling, needle exchange, and a few other services to addicted New Yorkers to help them to get by. And in this meeting, it came up that one of their staff employees was actually punched just on the threshold of their facility at Lenox and 125th Street here in Harlem on the way to work last week. And so what has happened is, as a society, because we have found that large mega methadone dispensing centers are economically more remunerative for the providers to provide like large facilities as opposed to distributed small neighborhood-based ones. The consequence is the community around and the vicinity around those centers becomes a self-reinforcing drug zone. That's where I go before to hang out. That's where I hang out afterwards. That's where I score drugs, because drug dealers are not dumb. The drug dealers basically say, where can I go where my population, my consumer base is densest and most numerous? And so they flock to those areas. And a consequence for the staff is that they now have to go through a gauntlet of people with issues. And as I said, just an anecdote yesterday about someone being punched on the way to work as a counselor.
It is changing. It's, it's taken over half a century for it to happen. And frankly, it's taken the majority of tragedies to be white for it to change. But not just in New York, it's changed. I mean, Staten Island is a predominantly white borough, but their OTP clinic is in a hospital in a white upper middle class single family house neighborhoods. There's lots of complaints about patients back and forth, but commuting, but it's there. And my own agency, we're not located in poverty areas. I mean, one of our outpatients is in a poverty neighborhood, but our other two locations are in neighborhoods. So it's changing. People aren't really opening their hearts the way they should be, as much as they're desperate because it's touching so many families.
I will just point out, Luke, that the program in Staten Island that you were referring to has less than 100 clients enrolled in that program. And 3 blocks from where I'm sitting right now, in the Lee building at the corner of Park Avenue and 125th Street, which is right at the Metro North station, there are close to 1,900 patients. So just to give you one building versus Staten Island, almost 2,000 versus 100. Just throwing that out there.
Shawn, the history is that this is society's garbage. We dump society's garbage in the neighborhoods that'll offer the least resistance. It's like, where do you put a prison? Well, drug users, opioid abusers are society's garbage. If you want to acknowledge that or not, that's the way it's been. That's why they're located there. And frankly, that's why the problem continues to spread, because it's not ever embraced as not a racial problem, not a poverty problem. Yes, it is racial. Yes, it is poverty, but not exclusively. Yeah.
I think this brings up the important role of stakeholders in trying to do any kind of new policy initiative, both the people in the neighborhoods where you would want to expand treatment centers, but also the organizations that do new policy initiatives. So I think this is mostly for Michelle, but other people can chime in. What are some best practices for interacting with sort of intransigent stakeholders, potentially who don't want to share data or are concerned that evaluating a program could show that it's negative or not as effective and cause them to lose funding? Are there, good ways for researchers to bridge that gap with stakeholders and policy?
Thanks. That's a great question, and I think that's a challenge that certainly in my time at the lab we've encountered, and certainly is very difficult. I think an approach that we use is is that we're very clear about the limitations of some of the other research methods that might feel more comfortable or maybe more familiar with partners when we're talking about potential methodologies. So we're very honest about from our experience what to expect, the limitations of the things you can say about different types of evaluations. But I'd say, yeah, it's something that is challenging, and we still, have experienced time to time. But I think we've learned that the best thing is to just be honest about, what our lab is can offer, and be clear about, offer options for alternatives if, the things that we specialize in are not the best fit for a different project, because certainly we don't want to ask people to do something that they are uncomfortable with.
So we are just about out of time, but I would like to open up that last question to anyone else if they have final thoughts on this interaction between researchers and stakeholders.
Yeah, and if I may, I think what Michelle was just pointing to is one of the strongest arguments, not the only argument, but one of the strongest arguments for something like community participatory based research, where the people in the communities are not just the subjects of your research, but active participants who get to actually shape what kinds of outcomes and what kinds of things we value, because it's very easy using kind of our more traditional policy analytic tools to look past things that people value a great deal and to make people feel as if they're simply the subjects you're swooping in and studying them for a while and then publishing your little papers and moving on. So I think that change in orientation can help with that.
I agree totally with that, Michael. We're constantly, those of us who are direct service providers are constantly being required, mandated to follow best practices. And my problem with that is that they don't ask what best practices are. They tell us what best practices are. And we're the ones day to day, person to person, who are doing this work. We shouldn't establish best practices alone, but we certainly should be included and have not been.
Excellent. Well, I would like to thank all of you for being here and invite everyone to stick around for our final panel of the day on education, leadership, advocacy, and change. And it's been great. It's been a great day. And thank you so much for participating. And please look for the Nathan Fellows applications if anyone is interested, and for the upcoming Effective Drug Policy Conference.
Thank you for the
Very much.
opportunity.